All right, good morning. Welcome to the TBI Topics webinar on Pediatric Return to Learn After Concussion. My name is Kelsey Kowalski with Harborview Injury Prevention Research Center, and this is a joint project with the Washington State Department of Health. As we get started and as people are coming in, wanted to briefly let you know that we have an online discussion board where we can continue the conversation after this webinar. It's called TBI Topics for Health Professionals. Where we host our webinar recordings, discussion questions, resource sharing, and Ask the Expert Q&A sessions. So we'll be continuing the conversation there after today's webinar, so we hope you'll join us, and you'll get an email near the end of the webinar that has direct links and everything you need to join and continue discussing this. So today's discussion questions are going to be thinking about what other programs or strategies have you encountered for reintegrating individuals after a brain injury? And what other communities, professions, organizations could or should be included in supporting individuals after a brain injury. And that'll again be on our discussion board. So today our first speaker is Dr. Monica Vavilala, who is the director of Harborview Injury Prevention and Research Center, also a professor of anesthesiology at the University of Washington, and lead for HIPRC's brain injury section. And so she will be kicking us off. So thank you, Dr. Vavilala.
Thank you very much for organizing this, and it's great to be here. We're excited to see how many of you are here from where, and look forward to the engagement during the discussion section. So we're going to talk about an innovative student-centered return to learn plan after concussion that we launched here in the state of Washington. The genesis really was in 2014, and we've spent a number of years trying to understand what our state needs are and try to develop a plan that could address some of those needs. So the objectives for this presentation are to define concussion, to talk about the symptoms, to present some information on the return to learn's landscape as it's happening nationally, and to discuss our pilot project on a student-centered return to learn practice program that we have had here in Washington State. So to begin with, concussion is defined as a mild TBI resulting from a direct blow or transmission or impulsive force to the head. It can be rapid in onset, short-lived duration, and without significant neurological impairment. Concussion affects over 1 million students, and in 2017 alone, we estimate approximately 16,000 to 29,000 students have been diagnosed with a concussion. This does not speak to the number of students who have in fact suffered from a concussion, but that information did not get transmitted either from the healthcare provider to the school setting or was not reported to the school healthcare professional. The Berlin Consensus Statement, which defines concussion, does not provide return to learn guidance, largely because of the lack of evidence around the best practice on return to learn. Now, concussion symptoms, most of them resolve within 2 weeks, but over 10%, so approximately 13%, have symptoms at 3 months. And we're trying to figure out who those students are so we can provide better care for them during transition periods between diagnosis and schools, and between schools and then thereafter. So concussion symptoms fall into 4 domains. Physical, as you can see here, there are a number of symptoms. Cognitive issues can occur with memory loss or lapses, attention difficulties, and changes in processing speed. Students can become emotional and exhibit signs of depression, irritability, anxiety, and become socially isolated. And sleep, which affects academic performance and overall functioning, can also be problematic as students have difficulties with going to sleep or with frequent awakening. If we look at the national landscape, the map here in purple, and it's only purple because we're the University of Washington, I'm sure, it's purple, is that every state in the country has return to play laws. And we were the first state in the union to passed such a law, and it has been adopted nationwide since. If we look at the return to learn landscape, however, right, so some accommodation, some plan for return to learn, you'll see here that far fewer states have return to learn laws. As of June 2017, the states in dark purple have enacted policy. And none support persistent symptoms. Few recommend evidence-based return to learn practices, and 47 to 77% of school districts nationally, in fact, lack return to learn protocols. So this is an unmet need. So we've done a really good job of saying don't go back to play if you've had a concussion unless you're cleared, but we haven't really done much about academic performance and learning. We think there are 5 essential components of a good return to learn protocol, and these are derived by consensus and are recommended. In that, a return to learn protocol should be able to identify a concussion when it happens, and we still have problems with this. There should be screening and assessment processes in place. There should be systematic communication between medical and educational systems. Students should be tracked over time for either resolution of symptoms or worsening of symptoms, each of which requires an action to be taken. And then professional development for school personnel is important because teachers need to understand what concussion implications are for their classroom. And then outcome measures are necessary to measure academic success. This is largely lacking in that we don't really understand which protocol is associated with the least disruption to academic success after a concussion. There are return to learn resources, but schools don't always know how to implement them. There are a number of free online RTL resources available to schools. The Centers for Disease Control and Prevention's Heads Up program, REAP, Brain 101 are some examples. And there are 4 programs recognized by the CDC as best practice: Brain Steps, Cincinnati Children's Hospital School Reentry Program, Georgia Concussion Institute, and there's a Concussion Management Protocol program in Lincoln, Nebraska. Now, even though these are recognized as best practice, however, the data showing that these programs are effective at a population level are lacking. So the best practice protocols don't all do the same thing, and we put this table up here to sort of illustrate that. So the scope varies by program. For example, the Concussion Management Program in Lincoln, Nebraska involves protocols in schools to respond to students with a concussion, and materials include daily post-concussion checklists and a graduated RTL. The student connection is upon concussion identification. The base organization is the school district, and this is all really good. This is really good work. The gap here is that they don't really assess implementation and fidelity measures and see whether they're complete and how good adherence is to the local protocol. Another program, for example, just to compare, is let's look at the Concussion Institute program in Georgia. This is where a multidisciplinary team works with education coordinators to find accommodation for schools and students, builds relationships, and this relies on a referral after the injury, and the base organization is the hospital. And yet this does not address identification and short symptom duration support in schools. So these are really good efforts. They're not streamlined, and the funding for each of these varies. And so one of the biggest barriers to implementing a return to learn protocol in schools has been the lack of dedicated funding for this effort. So as I mentioned earlier, the program effectiveness with students for these programs remains untested. There's really no formal program on the West Coast. REAP was disseminated in Washington State, but had a low adoption. So the Pacific Northwest is largely rural, which adds to the complication in terms of actually dissemination and implementation of practices. We don't have return to learn legislation. And in Washington State, only 8 public school districts offer any return to learn guidance or protocols or programs for their students. While 70% have athletic trainers, they're mostly located in urban areas, even though the Pacific Northwest is largely rural. And in Seattle, formal accommodations are rare and require a 504 plan. And in addition, there's underreporting on concussion, and so there's no streamlined process for healthcare providers to communicate with schools in the state, leading to a denominator problem. In other words, we don't really know what the concussion burden really is, except for those cases which are identified. We conducted a study last year to understand the variations in concussion care at schools and cost. And the first slide here refers to the care that they received. So we interviewed 18 youth with concussion and 16 parents about their concussion recovery experience in schools. And if you take away nothing from the slide, what should be apparent is that the table or figure that is up on the slide, there's a lot of like different shades of color or black and white. In other words, there's a lot of variability in how often students were kept out of school, kept out of sports, whether there was phone calls made. And those variations in care actually are there regardless of the day or week after concussion, and regardless of symptoms. So families reported to us that they're the ones they're the ones who report concussion, thereby initiating services, and this places a large family burden. There are large barriers to receiving care in schools, largely due to communication between medical providers and school staff. There's insufficient knowledge on the part of school staff to address this, and lack of school protocols and services. And so families really felt like there's a need for systematic solutions. So in a parallel paper, we describe the cost incurred by families to when they're taking care of children with concussion. And these costs extend beyond medical bills and insurance. There's a lot of costs resulting from time from travel, parents needing to take sick leave, students missing school. That adds cost in terms of sometimes needing to hire people to take care of their children. And then additional academic support costs exist for those who want to provide tutoring for their students who miss classes. In a national survey of parents of children 14 to 18 years, 96% of respondents believed that parents should inform schools of concussion. 92% felt that return to learn should precede return to play, and this is something we agree with. 89% felt schools should provide return to learn adjustments, and the sources of problems are poor communication between healthcare providers and schools, disagreement regarding RTL decisions, and lack of teacher involvement that hampers RTL care. So in 2015, recognizing this need across the state, we convened a summit of stakeholders. And a partner of mine, Laura Wittes, who's going to be speaking next, has been amazing in terms of helping us think through and actually leading our community engagement perspective to try to work to address this problem. So we wanted to understand return to learn in Washington State. We wanted to develop something that wouldn't cost a lot of money. And we wanted to provide an implementation guide for schools that they could adopt and that we could evaluate. This culminated in a paper that we published in the Journal of School Health, and we used a mixed methods approach at this summit to understand from different people, 83 educators, 57 school nurses, 14 administrators, and 30 parents, so a pretty big number. So, and representing 144 schools in rural and urban areas. We identified that the unmet need domains and recommendations were: there's a lack of school policy, there were barriers to providing and receiving accommodations, wide variability in communication patterns, and all stakeholder groups recommended and desired really a best practice, development of some policy that was easy to adopt, that didn't require a lot of resources. And so we concluded that Washington State children have an unmet need upon returning to school after concussion. The student-centered RTL model and checklist for implementing guidelines can help schools provide timely RTL services following concussion. So this is the map of the schools that participated in this survey and project and summit. And you can see that we had participation from elementary schools, middle schools, high schools, administrators, teachers, and school nurses. So again, a rich group of collaborators thinking about this problem. And we developed an initial conceptual model to think about how do we address this? And it seemed to be some domains that emerged. There seemed to be the communication context, which was the elephant in the room. And then within it, the external context, which is how do state laws and district policies affect the return to learn practices? What are the organizational financial resources? Are there incentives for schools? And then is there state level coordination? And then the school context, which is there cultural readiness? Is there a champion? The guideline context, how cumbersome is the protocol that we provide? Can schools effectively adopt REAP and Brain 101 with little resources and external support? And then what are the accountability and performance feedbacks? And how do these all interact to really provide a culturally relevant and student-centered optimal RTL context? So our overview of return to learn here in the state has been to think about really the need to provide implementation support, the need to use, for schools to use this, and then to sort of have built in a continuous assessment process. So we think it's really important to identify a local champion, to really get administrative approval, engage stakeholders, assess local environments, and go through these steps written here on this slide, and then followed up by implementation, which is to provide some staff and professional development, engage the parents and communities. And we've seen this to be particularly problematic with schools that have a higher underrepresented minority group and a higher rate of free lunch programs because the PTAs are less involved. And then each of these buckets really, we think, have to be done. And tracking outcomes, we feel, is really important because otherwise, I can tell you our program works, but in fact, we have no data. And that's really the limiting factor for facilitating adoption. And the continuous assessment process needs to look at student level outcomes and academic outcomes. So we think of a student-centered pathway, something to look like this, where schools really, what we've heard here in Washington State is they don't want to be responsible for diagnosing the concussion, but once a concussion is diagnosed, I think schools are eager to follow a symptom checklist. And as important as it is to provide accommodations when concussion occurs, is equally important to return to students to classroom with no adjustments when symptoms resolve. And this is another area where students fall through the cracks because students aren't being assessed regularly. And so the use of a symptom checklist is really important with continuing adjustments, modifications. And we should expect that 21 days after injury, most kids are going to be able to go back to return to learn. But 10 to 20% of students will experience symptoms beyond 21 days and will need some form of a formal academic plan and direct medical consultation. So part one really of our plan is to obtain relevant information, injury conditions, baseline conditions, and contact information, which, believe it or not, is sometimes not always easy to find, and basic information on return to learn. And then use of a symptom checklist for longitudinal tracking, including pre-injury, and symptoms that are characterized into the different domains that are problematic, and then instructions on actions to take regarding the duration and severity of symptoms. There's inclusion of a weekly progress report, and information for parents and coaches that are also included. The adjustments are characterized into these domains that are problematic in concussion, and they correlate with the symptom checklist. There's longitudinal documentation and clear tracking of notification of clearance to the return to learn. So return to learn, I think evidence is emerging that it should be gradual and customized, that monitoring of academic progress should be collaborative, that students with prolonged symptoms should see a specialist, and there should be a referral process in place. And then screen time should not entirely be banned, but should be guided likely by symptoms. So these are some of our data from a pilot that we conducted in 2018. This is a map of the greater Seattle area. These are 13 schools from 7 districts, all public schools, all urban, all have an athletic trainer on site, and all have a school nurse, which is pretty amazing and not representative of what happens across the state. And all the plans in this pilot were managed by a school nurse. Although the program that we've developed does not require the presence of a nurse to implement. So the implementation pilot was conducted by providing a copy of the plan, and then providing a 30-minute coaching session, and then providing monthly check-ins with the schools. The schools returned their plans filled out, and what we were able to evaluate was return to learn provided to 34 students with concussion. Of those, of the 34 students with concussion, 22 plans were available for analysis. And what we learned from this pilot is that our return to learn program, the average time it took for a school staff member to evaluate a student for return to learn steps is about 14 minutes. The time between school notification and return to learn program start in this pilot was between 0 and 7 days. We think 7 days is too long, and we've learned a lot about this process so that we can try to move that closer towards the first 24, 48 hours. From time of injury to date of first evaluation was about 5 days. Again, we think that is still too long. And from time of injury to return to learn end was about 17 days. So again, you know, there's a large standard deviation around that, but this makes it pretty clear that students actually need a plan in school because they're having symptoms that are either unrecognized, recognized and untreated, or treated and not optimized. Most common symptoms that were reported during the pilot included drowsiness, sleeping more or less, the presence of headache, light sensitivity, feeling slowed down or foggy, all of which affect learning. The most common recommended adjustments that were made during this pilot are to remove from physical activity, allow rest breaks in quiet areas, reduce or limit or remove screen time, no academic testing. Those were adjustments. I'm not saying that happened during the entire duration, but at some point, provision of extra time and assistance on assignments, and then allowing students to visit with a supportive adult. So a return to learn plan, what we heard from people who used it was that it really helped school staff provide weekly follow-up until symptom resolution. It helped prioritize concussion at the school. It provided return to learn guidance for teachers and counselors. It empowered other school staff besides nurses to be part of the return to learn process. It facilitated formal guided communication. It provides individualized adjustments and reduces concussion care barriers. So modifications that we made to our pathway based on feedback that we received is that we made it shorter. We left more space for comments, and in a world where everything is bullets and check marks, people really want to tell us what's happening, and I think that those qualitative pieces of feedback are really critical for us to understand the context of how to continue the refinement process. And then we are still working on how to integrate this better into existing school systems, and of course, trying to secure funding for this project has been a challenge. We are working with our policymakers at the state level, with other sources of funding to try to see how we can improve the reach of this program. We are licensing the Return to Learn program here in Washington State, and it's really quite reasonable. And if any of you is interested in learning more about how this works, please contact Kelsey Conrick at rtluw@uw.edu. Really like to thank participating schools and the number of dedicated staff and faculty and community members without whom we could not have launched this, this effort. Thank you very much.
Great, thank you, Dr. Vavilala. And next, I mean, as Dr. Vavilala mentioned, the school nurse voice has been very important to developing and implementing the Return to Learn program. And we're very pleased that Laura Wittes has joined us to help share that voice and that perspective. She's been a partner with HIPRC on this and other projects. She is a board certified school nurse and the director of health services at Renton School District. And that school district serves over 15,000 students across 4 high schools, 4 middle schools, 15 elementary schools, and an early childhood center. And in October of 2018, the school district reported that 49.2% of their student population was on free or reduced lunch. So we're very happy to have you here to share your perspective today. Thank you very much for joining us.
Thank you so much for having me. Yes, so I'm Laura Wittes, as was said, and I've been a school nurse since 1994, primarily at elementary school level, so fewer numbers of concussions, but definitely it's been part of my experience as a school nurse. And no conflicts of interest or any of that thing. And so I was asked to speak about kind of our journey as Renton School District together with Harborview. About the Return to Learn. And it began in 2015 when Dr. Fred Rivera approached us about a pilot project to collect concussion data from our student athletes to develop a database that people could mine to learn more. And from that first connection, I wound up being invited to the Concussion Summit and that Dr. Vavilala talked about. And it was a really exciting conversation to see so many people coalescing about the importance and the need for Return to Learn. And yes, we have a lot of student athletes in our system, but all of our students are students. And the work of youth is to be a student and to learn. And so to lack the focus on helping them return to learn is great that so many people identify that need. And as was spoken, the draft Return to Learn packet first came to me to review in November of 2017, and it looked great. I had some comments and that type of thing, and they were incorporated by the Harborview team. I also had my kids, who at that point were in high school and college, look at it, and they had some really great feedback about it. And then a friend who lives in Sweden, who had a daughter suffer a concussion, also took a look at it, and she's like, I wish I had this. I looked everywhere and could not find this information. So it's not just a need in Washington, it's an international need to be able to help our students get back to learning. In January of 2018, Dr. Vavilala came to the Puget Sound School Nurse Supervisor meeting, and so it's a group of my counterparts from 3 counties, and we represent about 36% of the state's public school students, where she presented the work and solicited people to pilot the packet. And so that was really exciting to get that word out. And then in February, one of our high schools began piloting the packet, and unfortunately, football season had already happened, and that's when many of the concussions happened, so there were fewer. But always along the way, Harborview has been super fabulous about taking the input from people and making the packet better and better. And so this fall, the other 2 of our comprehensive high schools started using it a little bit, and the packet just keeps getting better and better. So what have some of the challenges been, and what have some of the successes been? So one of the challenges is who owns it? Who's going to be the champion that manages this in the school setting? And nurses are many people's first thought. It's a head injury. The nurse should take care of it. That makes a lot of sense. Other people come at it from, well, it should be the counselor, because the adjustments that need to happen for the student are classroom related, and counselors work much more closely with teachers about adjustments in the classroom and that type of thing. Or perhaps it's the athletic trainer, because so many of the concussions happen to our student athletes. And there's advantages and disadvantages to each of these folks. In our district, we have 0.8 to 1.0 FTE for the high schools. The counselors, there's 4 counselors per high school, so they have a smaller caseload. The athletic trainers are only supposed to work with student athletes, and all of their hours are outside of the school day, so their opportunity to connect with school teachers, staff is limited because of that. The counselors in our district have a lot on their plate, as everyone does, but we've transitioned from semesters to trimesters this year, and a lot of that load happened to land on their shoulders, and they have different initiatives that they've been very involved in. And so it landed with the nurses who wanted to champion it, but like Dr. Vavilala was saying, is that the packet can be done by anyone. It doesn't require a health background to do it. So the nurses who have participated really have appreciated the guided thinking that the packet provides about how to move through the process, and to how to support the student through the process, and how to connect with school staff. The guided thinking has been great. And the packet provides a lot of education along the way about what concussion is and about best practices for healing. So they've really appreciated that the educational piece is incorporated into it, so that they don't have to kind of start from zero all along the way. One of the challenges has been that this is one piece, and that we need to have a more comprehensive school-wide protocol, to incorporate it into the bigger school picture, and kind of be more specific about who does what and when, and to kind of move forward that the packet starts earlier in the process than it sometimes does. A sticking point for some of the nurses has been, is medical clearance required? Because with the return to play, that is such an important piece of it, that either the healthcare provider or the athletic trainer needs to clear an athlete before they begin playing a game. And the packet isn't designed to need that medical clearance, because if there's no more symptoms, move forward. No more adjustments are needed. And so that's a little bit of a shift in thinking for some of the nurses. There are some workload issues. In our district last year, there were no additional supports for the nurses. They got to see every student that walked in the clinic and got to file every piece of paper and do all of that. And so we're overwhelmed. And in recognition, the district has increased, has provided a little bit of funding to have a health service assistant, so that some of the first aid needs, some of the clerical needs can be met by that person, freeing up the school nurse to do some more of the case management type of work and connecting with parents and healthcare providers and students. And so that's been a real boon to nurses' ability to connect with this return to learn packet. Kind of additional workload issues for the nurses are, like the first 4 bullets are things that are all legislated duties that nurses have to do in the school setting here in Washington. That for students that have life-threatening health conditions, they have to have treatment orders and medication before kids come to school. It's an ongoing process. It doesn't all happen by the first day of school. There's all the requirements about medication, getting orders from doctors and parents, special ed evaluations, immunization compliance, which with the measles outbreak in Washington has been a focus of attention. Pardon me. And meanwhile, we were transitioning from using our student database to the Washington immunization system. So kind of further complicating things. And then nurses have all the students coming into the clinics, interrupting and whatever's happening. So they're just challenges for workload, but the packet helps with that. Pardon. So we've had athletic trainers in Renton for about 3.5 years. And in my opinion, they are a direct result of the return to play legislation that happened. The return to play legislation put districts on notice that they needed to provide certain things to their student athletes to prevent further injury from their concussions. And to meet those needs, having the athletic trainers there to provide the medical clearance has been great for the students with concussion, and it's also providing better care for our student athletes. So it's been great having them, and I don't think many of the districts would have gone down that pathway as quickly without the return to play legislation. They do have limited hours. Some of the issues with the athletic trainers have been that there turnover in the athletic trainers, turnover in the nurses, the health assistants are new. So the communication channels have to keep evolving, but they evolve and they work to the benefit. So our student athletes are coming to the attention of the school nurse, so the school nurse can help support them. One of the things that was spoken of previously was about the connection between return to play and return to learn. It's going to take further understanding in this community more broadly than school, I think, as well, that before returning to play, return to learn needs to be completed. You know, again, students' primary activity is to be a student. Being an athlete is something on top of it. And if you can't be a student, you probably shouldn't be an athlete back into the athletic field. And so that's an area that we need to fine tune some more. In terms of the impact of the packet for teachers and other staff, kind of classroom staff, it's really helped increase their awareness of their students' concussion in particular, but also concussion in general. Looking at concussions with the 4 domains of impact has been kind of an aha. It's changed the way that people think about it to kind of have a broad framework as opposed to just random symptoms. It's helped people understand concussions better. And one of the really big ahas for people is that many of the teachers were just simply unaware that emotional impacts could be related to a concussion. And you know, it's not just that the teenager is tired, it's not just they're hormonal, it's not just they're in a grumpy stage of life, that it really can be connected to their concussion. So it helps them relate to their students with more empathy and understanding. The teachers have also really appreciated the specific actionable adjustments that are part of the packet. You know, just knowing people want to do the right thing, and so having something that really guides them towards doing the right thing is greatly appreciated. The teachers have also appreciated having feedback about how students are doing. You know, being able to see that the student is recovering or they're not. It's really helpful to know how to work with the student. And then for everyone, the packet, you know, when symptoms continue for 3 weeks, that we need to move down the pathway to having a 504, having that clarity, because there's follow-up and students don't get lost in the mix, that's really a helpful thing. Students have had a mixed response, mostly positive. Largely, they've greatly appreciated that someone is trying to understand their experience of the concussion, and that they're not the only one that has had that. There's a checklist. Wow, the other people must be having similar symptoms to these. And it also gives students some vocabulary to talk about what they're experiencing, because not every, everyone has their first concussion sometimes, and so many students don't have the language to communicate about that. The students have also really liked having some specific adjustments recommended. When your brain's hurting, to not have to think up what's going to help, when you have no experience with this, it's sometimes the adjustments that are in the packet have been perfect, but sometimes it's been a conversation starter about how to further refine what's needed in the school setting for that particular student. And kids come away from it feeling very empowered about how to be able to move forward. Kind of the mixed part of it is that sometimes kids are like annoyed that they have to be out of class to do the packet, and doing the same thing multiple times. The repetitiveness can be something that they've commented about. With the time out of class, if they're having to take rest breaks because of headaches and whatnot, and then to have a little bit of additional time to do the symptom checklist, they're already feeling stressed out and behind, and so exacerbating that can be a little bit of a source of annoyment. But the symptom checklist is pretty quick and easy to use, so I'm not sure how it could get any more brief, but there we have it. In terms of the work with families, I'm sure you are all aware that there's a broad understanding what concussions are in our families. That some families are in a concussion specialist right away and are doing a lot of follow-up, and to the other end of the spectrum, that parents, I had dings when I was a kid, I don't need to take them into the doctor. So, for some families, getting the initial diagnosis can be challenging. And so that just provides nurses with lots of opportunities to really individualize the conversations that we're having with families. A challenge for families when they are trying to connect with the school about concussions is, who do they need to let know, and what do they need to let them know about? Going back to, should it be the nurse, the counselor, the athletic trainer, or somewhere else entirely? Because we haven't refined the process, it's not clear who's supposed to know. So maybe they let the teacher know. Most of the time, the teachers let someone else know, not always. Maybe they let the counselor know, maybe they let the nurse know. So kind of having a system in place so that all information about concussions goes to whoever the champion is at that school, the school nurse, whoever it is. So that person can then get the packet initiated and get the information out to the school, the teachers, about what adjustments need to happen for that particular student. Access to care is always an issue. People have different insurance, work schedules, transportation options, and so for some families that has been a barrier. And then following up, a lot of families like, okay, we let you know about it, we're done. So getting back to the healthcare provider, symptoms aren't resolving. If they do go to the healthcare provider, getting back to the school with the updates, that's just an ongoing challenge. In terms of the school connection with healthcare providers, communication. Healthcare providers are crazy busy in their clinics, nurses are busy, and so everyone's relying on parents to transmit the information back and forth. Sometimes that happens with great clarity, sometimes it happens not at all, and other times the message is changed along the way. Nurses love it when a release of information is signed at the initial diagnosis of concussion, so that the communication can happen directly between the nurse and the healthcare provider. But that doesn't always happen, but it's ideal when it does. One of the things that the nurses have and the school people in general have found to be incredibly helpful about using the packet, is that it takes the onus of understanding what needs to happen in the school setting off the doctor and lets the experts in the school setting make the adjustments. Just as having the doctor make the diagnosis, the school people don't have that ability to do that. So that's been really great. The packet's just a super bridge between the school and the healthcare system. We still see recommendations coming from healthcare providers that seem kind of old school, that the student should have no screen time or no reading for 2 weeks. And when we do the packet and the student's only symptom is they have light sensitivity and that wearing a hat in school so that the fluorescent lights up in the ceiling aren't bothering them, it's a limitation on the student's ability to access learning if we're feeling the obligation to honor the request from the healthcare provider to provide no screen time and no reading for 2 weeks. So kind of taking the burden of figuring out what needs to happen in the school setting off the healthcare providers and putting it on the school people by using the symptom checklist and the adjustment can be really great. So documentation, as was previously mentioned, figuring out, so our district uses Skyward, which is a student information system used by many districts in our state. And so we've been talking to them about how can we get the assessment page, the symptom checklist into the system so that the documentation can happen easily and that bits of paper aren't lost and that type of thing. And then equally, how can we get the adjustments into the system so that they are easily visible and accessible to school staff. So the individual healthcare plans, the 504 accommodation plans, all exist in Skyward. And so teachers are used to accessing them that way. And so if we could get the concussion, return to learn after concussion in there as well, it would just kind of facilitate that communication with the school staff, I think. Financially, the work needs to be sustainable for Harborview. I wonder though if licensing fee are going to leave some districts out. There's a bunch of districts around that are looking at millions of dollars of cuts this coming school year. One district is looking at using the state allocation of nursing, which would be a 1 to 10,000 student ratio. And so, cutting a lot of nursing to get to that point, kind of taking on an additional cost of a licensing fee when you're laying off staff is a question that's out there. So if someone has a huge grant that they want to send towards Harborview, please do so. And kind of next steps, I think continuing to streamline and refine the packet is great. I mean, it's gotten so much better over the past couple of the year or so. At every iteration, I think, oh, it can't get any better, but it does keep getting better. I think getting a middle school and an elementary school version is important. This morning, I was meeting with a parent and student of a middle schooler, and it was clear that the language that's designed for high schoolers isn't quite perfect for a 6th grader, for instance, and definitely not for elementary school students. And we definitely have younger students who have sustained concussions. Getting the packet into other languages besides English and Spanish, well, the symptom checklist into languages other than English and Spanish would be great. We have a lot of students who speak a lot of different languages. And then I would love to see legislation about return to learn in our state, because it just motivates all the parts of the system to work together to the betterment of our students in much the same way the return to play has bettered the outcomes for our athletes. So there's my contact information, and what's next?
Great. Well, thank you very much for your presentation. We're going to move into our live Q&A. And this is going to be a joint Q&A, so you can ask questions of one or both speakers, and we invite you to do that. If you look in your Zoom tool, it's probably on the bottom of your browser. I know some people's look a little bit different depending on your computer setup, but it will say Q&A. And if you type your questions in there, they will be visible to other attendees, and then I'll also read them on over the mic so that everyone can hear them, and then we'll talk about them together. So actually, we have a couple questions waiting for us already in the Q&A. So first of all, do parents have to give permission to utilize the RTL packet?
No, we haven't asked for permission. We're just moving forward, doing the best thing we can for their students.
So that's correct, and that's been great. We worked closely with the Washington State Risk Insurance Program to endorse use of the packet, and they have, and so the schools are empowered to actually proceed.
Great. Is all symptom check subjective and on paper? Are all the symptom checks subjective and on paper?
We are using, well, there's a paper version and a PDF version, but it seems like for kids it's easier to give them a piece of paper, and yeah, they are subjective, their experience of it, yes.
Great. So there is some interest in how people can see the packet itself.
So if you'd like to email RTL at rtluw@uw.edu, Kelsey Condrick will set up a call, and then we can talk it through with you.
Okay. So another question is, one of the mentions was expanding return to learn beyond high school. So what are some potential changes or differences that we might see if RTL was developed for other age groups, either older or younger than high school?
I think Laura mentioned that there's a need, and we've heard this too from various elementary and middle schools. Laura mentioned the language. I think some of the language in the packet itself needs to be modified and simplified. Some of the action items that ensue based on that are mapped to symptoms need to be made age appropriate. And so those modifications are needed. And we're just brainstorming out here during this webinar that we probably could try to do that this summer because we'll have students and maybe we can sort of work towards that goal.
But I also appreciate the need for ramping it up. A friend whose daughter sustained a concussion in college soccer was very interested in learning more about this because she's trying to help her college-age student return fully to learning, and the accommodations that we were talking about work as well in high school as with some modifications in college. So
that's a good idea, Laura. Thank you.
Great. So do the RTL documents become part of a child's permanent school record?
Everything becomes yes, yeah, we keep these, yes.
We ask for copies of the completed ones to be sent back to us. We have, because we wanted to understand how well the packets were working for people and to understand what were the most common symptoms and accommodations, and that's some of the data I shared with you today. And so in a de-identified manner, the schools have been kind enough to send that to us. So we can actually give data back to the schools and share the findings, which I think has been largely lacking in the literature.
So how did schools, or I guess in our experience with RTL, how did schools get buy-in from local school officials and the medical community? How did that dialogue get started? And I think this person's saying they're asking from Anchorage, Alaska, with a school district of 50,000 students.
Oh, wow, that's great. Well, thank you for joining us. Alaska is part of the WWAMI region for us and a priority for the University of Washington. So we'd be glad to talk with you as well. So the engagement really began by holding this summit in 2015, and we gathered a list of names of people who belong to organizations for whom this topic would be relevant, like OSPI, the Office of Superintendents, the Nursing Association, Teaching Association, and then we sort of compiled a list and contacted folks, and then also we knew of clinicians who were interested in this area, and so we gathered people to come together. And the first step was really to say, like, this is a problem. We share our experiences. So different groups presented their challenges. We began to have a dialogue, and we worked together to figure out what this conceptual model should look like, and then from there continued to work with Laura and others to see how we can penetrate the community. We invited some parents, we invited some policymakers, and so it really was an integrated conversation. I mean, I think everybody recognizes it's a problem. I think the key is how do we actually get a plan into the reach of the schools at the lowest cost possible. That's really, and boy, Laura, I mean, if that's the cuts that's happening, I mean, I think we'll have to figure it out. We may have to become even more creative in terms of thinking about how to get this out to ultimately the students, right, and their families. So, yeah.
Great. We also had some information shared, I think, by someone familiar with the Brain Steps program, and they just wanted to mention that that program does start, or the goal for that is to start immediately after injury. So I just wanted to share that information.
Yeah, thank you. And it's a good program. It's coordinated. It's one of the programs that I mentioned in my talk. I think there's a cost to that, and I think that we are really interested in seeing data from that project to look at student achievements. I think that would be terrific.
Great. Would the use of this RTL program require legislation if it was going to be used in another state?
No, it does not, because the material are really based on best practice, based on evidence, and based on input from the range of clinicians and healthcare providers. I mean, this was developed by physicians, nurses, teachers, and parents and administrators together. So this doesn't represent the viewpoint of one group. And I think that's what makes it really special. And there's nothing contextually different about Washington State here. Do you agree, Laura? Or?
Absolutely.
Okay, I just want to make sure.
Yeah.
Great. In addition to supporting cognitive difficulties with accommodations, do you have thoughts on how to combine this with structured training of compensatory cognitive strategies for students to use? So there are examples they give are calendars, reminders in the phone, attention and focus strategies.
Right. So we haven't really done that in this. This is really aimed at, it's not necessarily aimed at optimal recovery after concussion. It's aimed at accommodations that fall within the purview of the school context and what schools can do to facilitate return to learning. This is, it may be that other things can be included, but I think, when the action items here are mapped to things that teachers and school staff can actually act upon.
Yeah, and this morning in the conversation, the student mentioned that organization was difficult. And so then the team brainstormed ideas about, kind of specifically what parts of organization. And so we're able to fine tune for that student in that school what works. But the conversation started because of the symptom checklist and looking at adjustments. So, the larger adjustment is in the packet, but the fine tuning of the adjustment happens in the context of that student and those classes with those teachers.
I think that's a really great point. I mean, I think if we included everything, all the solutions, that it would become a little bit burdensome. We're trying to make this actually simple to use. And I think we have to assume that if a student says, I'm having trouble with organizing, remembering when my tests are, that teachers typically would say, why don't you use some sort of a calendar system. I don't think, do you agree that we don't need to put that in there, or do you think we should?
No, I think.
Okay. We're actually learning from each other during this webinar, so this is great. Thank you.
Great. We had another question about contact information on RTL. So I can speak to that we will go ahead and include that in the email coming after the webinar with the evaluation. We'll include all the contact information so that you have that easily accessible. In thinking about return to learn, I mean, are there any lessons from developing this program that you think could be applied to other contexts in helping people with brain injury to reintegrate in other aspects of community and other aspects of, or maybe at other ages or kind of in other phases of life that you think could be applicable?
I mean, I think, so we're not talking now about concussion, which by and large resolves. We're talking about individuals with persistent symptoms. And so, you know, I guess I do see an opportunity, I think, for there to be some sort of an anticipatory guide for what people may expect, and then trying to provide some guidance on thinking about how to navigate the world if you're a survivor. And there are some resources out there in the public domain on, you know, self-help aids, and the Brain Injury Alliance of Washington is an organization, and there are a number of these organizations across the country that help survivors, TBI survivors, navigate the complexities of the world, and they're an excellent resource for TBI survivors. I just want to mention that's a very important community organization to reach out to if you know of people with TBI.
Another piece is that there was, we talked about feedback from kind of a lot of different stakeholders, and has there been much feedback, or what kind of thoughts have you heard from specifically thinking about school counselors and athletic trainers, which were mentioned were kind of part of the team that's involved in reintegration for a lot of these students? So what's been some of the feedback from those groups?
So there's been, they recognize the need for return to learn and want to make that happen. In our district, the counselors were overwhelmed, and taking on working with the packets and students about this was not something they were up for, but they appreciate that it exists. And as they're seeing it in use more, they're more and more interested in using it themselves. You know, learning something new is always hard. So, you know, but seeing, and I kind of think about this the way I think about EpiPens, and you know, that we had to do a lot of work when the flood of EpiPens started coming to our schools, you know, and training each staff person about how to keep kids safe from whatever their allergens are. And now teachers are like, okay, another kid with peanuts, another kid with fish, and you know, it's a routine sort of thing. And I think that we'll get there kind of using this packet, that people will, okay, I understand what concussions are, I understand better how they generally impact people. I appreciate how this packet is individualized to this student. I don't have to do every adjustment for every student. I just need to do what this particular student needs. So, so I think, you know, we're kind of growing the awareness of all the players in the school setting about that.
I think one of the conversations we had when we came and presented at one of the schools maybe a year ago was that I think athletic trainers are very aware of the return to play laws, and athletics is a big cultural plus point, right? I mean, we like our athletes, we like sports. It's a big part of our culture. So sometimes there's an unspoken tension between athletic trainers and teachers and nurses, where the priorities for return to play are really strong. And I think what I heard is that this kind of a structure gives teachers and nurses, it empowers them to say, no, well, return to learn is also important and they're not ready. Instead of just them saying they're not ready in my opinion, right? It emphasizes and reestablishes the balance between learning and athletics. And I think that this can quantify why students are not ready for return to play. So the teacher and the nurse can say to the athletic trainer, this kid has to still sit out from return to play because they're not ready for return to learn yet. And I think the second advantage really is that there are components in this packet that athletic trainers and counselors can also use. You know, there's components of their in it that they can use for accommodation. So I think there are some benefits for treating the student as a whole. And I think this sort of adds to that second half, which is the educational component.
And I guess kind of bouncing off of that, it puts athletic trainers and the kind of the school, the academics, in alliance sometimes when parents are pushing really hard to get their student back to play. So the athletic trainer can say, not only are they not ready to play, they're still having issues learning. It helps the conversation with the parents that are pushing hard when everyone in the school setting is seeing that the student's not ready to move forward.
That's a great point. Thank you. Yeah.
So how do you get the information from the packet to the medical provider? We found we have information, then a student comes back with medical clearance, well, we still have evidence to the contrary.
Yeah, so this is a challenge, right? And the ways schools communicate with medical professionals varies, I'm sure. So, I mean, I should let Laura answer this question. How are the different ways that schools can communicate with providers?
Well, if there's a release of information, that helps a lot. You know, some providers are easy to reach by phone, some email, some we communicate by fax. But by and large, it's relying on parents or students to either bring paper back and forth or to verbally transmit the message. It's not ideal with regards to concussion or much else.
How many schools actually communicate electronically, like a board, or, you know, is there like I'm sending a note to a parent on an electronic format, like Skyward doesn't do that? Is that correct?
No, I mean, it kind of hooks into email.
Mm-hmm.
So,
it hooks into email.
With parents, right?
Okay.
Yeah, you know, assuming that families have emails, and more do, but not all.
Not all.
Yeah, but a lot of the providers won't email because it's not a secure system.
So we have challenges there.
All right, and we had a comment of thank you for the nice presentation. So I just wanted to call that out for
Thank
you guys.
you. We're super excited. I think we had over 300 people, right, Kelsey, register for this event. And so
from across the country, a lot of different professional roles, school-based and non-school-based folks. So I've not seen any other questions popping up in the Q&A. So I think if we're ready to wrap a little early, we do have a couple announcements here at the end. Just to mention a few other resources that are available for continued learning. So the recordings for today's webinar will be available in a few weeks with captioning. So please expect an email from us kind of through that same Eventbrite channel that you've been getting announcements, and we'll have the recording. We will also, we value feedback. You'll also be getting a link to a course evaluation. We will include the contact information that was requested on RTL in that email, so you will have direct access to that information. So coming up, we are planning to have another Ask the Expert live Q&A session. We're still discussing what that topic should be, so if you have any thoughts on that, we'd love for you to share with us, either through email or through the discussion board where it will be held. And then in May, we will have another webinar on TBI and health disparities, which we're very excited about, and we will get that information out to you. And also, again, just to make sure it's clear for everyone that RTL, that program or packet is available outside of Washington State. So it's been Washington State focused because it was developed here. This is where we piloted it, but you can use it in other places as well. So I wanted to remind you that our discussion board is open and ready to continue the conversation amongst ourselves about thinking about return to learn and supporting individuals with concussion and with brain injury. And wanted to remind you today's discussion questions, which are what are some of the other programs and strategies that you've encountered for reintegrating individuals after a brain injury? And how do you see those programs as being similar to or different from what you've learned today about RTL? And then what other communities, professions, or organizations could or should be included in supporting individuals with brain injury? And are you seeing those communities being involved or not, or being invited to be part of the conversation? So I'd love to hear what you have to think. So please visit, it's tbi-topics.boards.net. And you should have an email either in your inbox or on its way to your inbox with those details on how to sign up for that board and join the conversation. So thank you very much for joining us today. We very much appreciate all of our attendees and of course our speakers. And please reach out to us if you have any other questions, and we hope you'll join us for the next webinar. Thank you, everyone.
Yay.